And thank you for joining us tonight for Illinois Bone and Joint Institute's 67th virtual YMCA Education Series program with the North Suburban YMCA. My name is Karen Brownlee, and I'm a personal trainer and the adult program coordinator at the NSYMCA in Northbrook, Illinois. This evening's presentation, entitled The Aging Shoulder in Active Adult, What's Normal, What's Not, is being recorded so that you will be able to revisit it again. Please feel free to tell your family and friends about it so that they too can view it once it is posted on the IBJI and NSYMCA websites. Shoulder pain is a frequent concern for aging athletes and active adults, and while some discomfort can be expected over time, issues like rotator cuff tears, labrum injuries, arthritis, and impingement may require medical attention. Understanding what's normal and what's not is key to staying active and avoiding long-term damage to your shoulder joint. Tonight, IBJI's Djuro Petkovic, MD, will help us recognize common shoulder problems and explore the latest treatment options and recovery strategies to keep us on the court, field, etc., and to allow us to continue to do the things we love to do. Dr. Petkovic is a board-certified orthopedic surgeon, fellowship trained in both shoulder and elbow surgery, as well as in sports medicine. In his practice, he addresses shoulder deformity, fracture, primary and revision shoulder arthroplasty, also known as replacement, including the reverse shoulder arthroplasty, a relatively new procedure that is useful in cases of irreparable rotator cuff tears. Dr. Petkovic also specializes in rotator cuff disease, shoulder instability, elbow pathology, and even knee injuries. Interestingly, Dr. Petkovic did not always know he was going to be a physician. He grew up in the Chicago area and went to Dartmouth College on the East Coast, where he obtained an undergraduate degree in economics. However, experience with sports injuries, as well as a growing interest in the sciences, led him back to Chicagoland to pursue pre-medical courses at Northwestern University, and then, ultimately, he obtained his Doctor of Medicine at the University of Chicago Pritzker School of Medicine. After that, he moved to the West Coast to serve both his internship and residency at Loma Linda University Medical Center in California, and even spent time treating limb deformities in Port-au-Prince, Haiti. Along the way, Dr. Petkovic learned to speak fluent English, French, Serbian, and Spanish. While in residency, he became fascinated with the complexity of shoulder and elbow surgery, which is one of the most rapidly evolving fields in orthopedics. He chose to pursue a fellowship back on the East Coast at the renowned Center for Shoulder, Elbow, and Sports Medicine, Columbia New York Presbyterian Medical Center in New York City. This allowed Dr. Petkovic to combine training in shoulder and elbow surgery at the first fellowship of its kind, while also gaining expertise treating high-level athletes, including the New York Yankees, the NYCFC pro soccer team, Columbia University Varsity Athletics, and other teams in the area. We are so pleased that he landed back here in Chicagoland, where he practices at the Des Plaines, Highland Park, and Morton Grove, Illinois Bone and Joint Institute offices. In providing care, Dr. Petkovic focuses on a patient-centered approach, which involves not only directing appropriate non-operative care when indicated, but also recognizing when the right invasive procedure is needed. According to Dr. Petkovic, every patient has different needs, and every problem has unique characteristics. The same injury in an 18-year-old does not get the same treatment as in an 80-year-old grandmother. My job, he says, is to educate and discuss with the patient how we can responsibly get them back to their desired activity level. In addition to working with patients, Dr. Petkovic has published numerous peer-reviewed articles and book chapters and has offered many local and national scientific presentations. He's also been on local television programs such as WGN Daytime Chicago, discussing keeping athletes safe from sports injuries, and has educational videos, audios, and even blogs available to educate us lay people about keeping our shoulders and elbows healthy. During Dr. Petkovic's presentation this evening, you might find that you have questions for him, which he will be happy to address at the end of the program. Simply type your questions into the question section on your screen, and I will receive them and relay them to Dr. Petkovic immediately following his presentation. I do ask that you please keep your questions general, as he will not be able to address individual concerns without individual consultation. If you do have specific questions, please contact Dr. Petkovic via one of the options that will be listed on the slide shown during the question and answer portion of the program at the end of his presentation. Two more things before I turn the evening over to Dr. Petkovic. First, I hope you'll join us tomorrow, Wednesday, September 17th, in person for Senior Palooza at the North Suburban YMCA, when at 12 p.m., IBJI's Dr. Ryan Harold will discuss common shoulder, elbow, and hand issues. Then, following Dr. Harold's presentation, join us from 1 to 3 for the health and fun fair part of Senior Palooza, where IBJI physical therapist Donna Ishak will be offering free balance and fall risk assessments. Plus, another 50 or so vendors will be on hand to answer your questions about nearly everything related to aging gracefully. There'll be raffle prizes and a whole lot more. To learn more about Senior Palooza, visit the NSYMCA's website. Second, please mark your calendar for our next IBJI and YMCA Education Series program on Thursday, October 30th at 7 p.m. Dr. Kurt Hutchinson, physical therapist, will discuss understanding rehab and recovery after hip replacement. Thank you again for joining us tonight, and thank you, Dr. Djuro Petkovic, for your time and effort in putting together this program to tell us about the aging shoulder in an active adult. What's normal, what's not? Dr. Petkovic, please take it from here.
Thanks for that introduction. That was very generous praise. But in any case, my name is Djuro Petkovic. I'm a shoulder, elbow, and sports medicine physician here at Illinois Bone and Joint Institute. And it's a pleasure and an honor to be given this talk to so many people. And hopefully I can educate everybody about a joint to which I've dedicated my career. So it's titled The Aging Shoulder in an Active Adult, What's Normal and What's Not. And what I want to convey to everybody is the reason I got into this field and why this is such an interesting joint. And here you see displayed from the Body World exhibit that was in the Chicago area and has been around the world, just how complex of movements the shoulder can do. You can see the one figure at the bottom holding up the individual above, and his arm is about 180 degrees from where it would be resting and holding up this person with whatever body weight they are. And then his other arm is extended behind him, whereas the subject above is basically rotating their arm and flexing and extending and doing all these complex movements of their shoulder. And you could see how much freedom the shoulder has. No other joint in the body has this kind of freedom. But with that complexity, just like any complex piece of machinery, comes a lot of potential for breakdown. And so, as many people have noted over time, as people get older, shoulders get cranky, shoulders get injured, and shoulders can get very painful. And so what I want everyone to come away from this talk is respecting and appreciating the beauty of the design of this joint without intimidation, and knowing how to approach these problems as we get older and want to remain active. So we'll see if I succeed through that. So the objectives here are multifold. First, I'm going to look at a very basic look at anatomy. We won't make it too complex, but I want everyone to be able to speak the same language and be able to keep up with some of the terms that I'm using. And then we'll look at some what the normal aging of the shoulder looks like, and then talk about the abnormal signs and when to seek help. And we'll go through examples of multiple different conditions that are fairly common, and then outline the treatment options, and then go over prevention strategies. And what we all want to aim for is having longevity with maybe not the excellent results that my countryman here, Novak Djokovic, has had at relatively ripe age of 38, right? But we want to be able to last as long as we can. So why do I care? First of all, I treat the aging shoulder. So I see everyone from fairly young teenagers to the most elderly of elderly patients who all have shoulder problems. And in the middle is that aging athlete population. I think one of the hardest things for people to come to grips to is their first injury, their first taste of going from a healthy state to an unhealthy state. And usually that happens in that, I guess we could put quotes around it, the aging shoulder, that middle-aged person that thinks that they are just as healthy and active as they used to be, but then they start getting these pains. And so I'm seeing these patients frequently for the first time. I have to walk them through this process, and then often, at later stages as well. So this is a big part of my life. I was a competitive athlete myself. I've played every sport that we could think of. And this is me. I got to throw the first pitch at this minor league baseball game in New York. And that was a big moment in my life. I threw the ball a little high, but I felt like I gave it a good go. But I'd like to stay competitive, but I've also been injured. So I understand the frustration of not being able to participate and wondering when you're going to feel normal again. And I want to keep active. I don't want to basically become a couch potato and with all the problems that come with that. So I understand that need to keep active, and I also understand the health benefits of that. So we'll start with some of the anatomy. So here are the bones that are involved in the shoulder. So there's the scapula. So the scapula is the shoulder blade, and it's a fairly complex bone that basically is almost floating on the back of your ribs and has multiple components around it. There's a couple little processes. One is called the coracoid process. This is called the acromion. We'll get to that later. And then this is the glenoid. The glenoid is the socket of the ball and socket joint. And then there's the humerus. The humerus is the arm bone that makes up the upper arm. And then the humeral head is the ball of the ball and socket joint, or glenohumeral joint. So this is probably the most important thing in terms of people talking about shoulders. This is what we mean when we're talking about the shoulder joint. And then there's also the clavicle. The collarbone comes across here, and that interacts with the acromion here to make up the acromioclavicular joint, or AC joint. So when people have AC joint injuries or shoulder separations, this is what we're talking about. And then we can overlie the muscles. So most of us think of the muscles in the shoulder as being the rotator cuff muscles. So there's these four muscles: subscapularis, supraspinatus, infraspinatus, teres minor. You know, these are names that you don't necessarily have to memorize, but those are the four rotator cuff muscles. We'll talk a little bit more about that later. But there's actually 17 muscles attached to the scapula, and so all of these sort of have to work together to have an efficiently working shoulder. So what is the rotator cuff? There's four muscles. Again, four muscles and tendons that surround the shoulder. Their purpose is to help lift the arm straight in the air or off to the side. So it helps get the arm in the air. It helps with rotating the arm to the side. So internal, external rotation. And then it keeps the ball firmly into the socket. So it basically pulls that ball into the socket. And when you don't have good rotator cuff tension, which a lot of people don't, and they sort of neglect this as they get older, then there's a little more play to the shoulder. And when you have a little more play and it starts kind of toggling around in there, that's when people start getting more pain and injuries and that sort of thing. So a lot of what therapy does, just to kind of skip to some of the point later, is to tension some of these muscles so we have a little bit more of an efficiently working machine here. We often get x-rays when we're in the office, so I'll talk a little bit about this. You want to look at, you know, and people ask, why do I need an x-ray? I know I didn't break my bones, but x-rays help us understand if there's arthritis of the joints, see if the alignment is off in any way, if there's a dislocation, for instance, though, usually we know when that happens even without an x-ray. We could tell if there's masses. Sometimes we're surprised by a mass around the shoulder or bone spurs that could be causing problems. So you would get basically 3 x-rays, though there's others you can get. You get AP, which looks from the front of the shoulder, which is this one. You get a scapular Y, which looks from the side, and sometimes you could see things like bone spurs that are hanging down and could be pinching, as opposed to this red line where it should be. And then you look at this axillary view, which looks straight down from the top. So you kind of get it from all the angles. And this is just one example of, what we look for in these x-rays is this joint line. The one to the left, relatively normal, nice, smooth ball and socket joint. And then the one to the right, you could see it's flattened. There's no joint space anymore. So this is what an arthritic shoulder looks like. So how did we get to this place where we're talking about the aging athlete? I think we could credit the baby boomer generations for kind of making this more mainstream by having this pattern of exercising both childhood and adulthood. Exercise became a thing not just for young people, but something that older people like to continue to do, and we've carried that on through these later generations as well. Simultaneously, we've had these set of chronic diseases that are on the rise: obesity, metabolic syndrome, diabetes. Some of these are associated with our more sedentary lifestyle, and we know by getting people moving, we can avoid some of these issues in addition to other health metrics. And then it's important to support that physical activity because we could increase our cardiovascular function. That's beneficial in multiple ways. You decrease muscle loss and bone density loss, which I'll talk about in a second, and improve mental health because as any of us who try to stay active know, we feel a lot better when we're in good shape. And so there's many physiologic changes of aging as a general rule. First, you get decreased muscle mass over time, or sarcopenia. And so this is just a little diagram which shows what happens in 35, 55, and 85-year-olds. So when you're young, a lot of muscle, very little fat. As you get older, that picture gets more and more dominated by fat rather than muscle. And so that's a problem for multiple reasons. You get decreased elasticity of the soft tissue. So elasticity, kind of like it sounds, like an elastic band. Your soft tissues become less stretchy and more brittle. And so they're more prone to injury when they're less flexible. And so that's something that we want to combat over time. Decreased bone density is an epidemic in some ways because as we get older and our bone density goes down, now when we have the same fall at, let's say, 85 versus 55, much more likely to break that bone. And so that's another problem that we're trying to correct. There's also longer recovery time. I've noticed this recently. I had relatively minor knee injury from snowboarding in March, and basically, whereas I would have recovered in probably several weeks before, I'm still dealing with that 6 months later. No, it's not bad. I can feel that my recovery time is much less than it used to be. There's also decreased balance, which may not be as much of a problem in the shoulder per se, but with decreased balance comes increased risk for injury. And so that's something we also want to work on. And then decreased fitness. And I put a question mark at the end because this doesn't have to be that way. We can maintain our fitness if we stick to a program. And so, but obviously decreased fitness leads to decreased resilience to injury. So in particular, what happens to the shoulder? First, you get this natural biologic degeneration of the soft tissues. And what I mean by that is all body parts are aging in some fashion or another, and degeneration just kind of means that it's becoming of poorer quality. And so that's happening in the shoulder, particularly in the rotator cuff muscles and tendons, but in other parts of the shoulder as well. If you add any history of trauma, there's a saying my dad used to tell me is the body never forgets an injury. And I tell this to my patients because it's true. Any injury that you had is going to remind you at some point in life because something happened to that joint, and whether it goes away for a while or not, it usually will remind you at some point in your life because there was a significant change in that body part that will basically accelerate that aging process, at least maybe accelerate it a few years, and then it sort of is catching up at a later date. Repetitive activity will lead to those micro tears. So you kind of, as I said, when you get stiffer soft tissues, they're much easier to have these little micro tears, and micro tears added up over time lead to macro tears. Then there's poor balance of stabilizing muscles. Again, I talked about 17 muscles attached to the shoulder blade. And so they all have to be in balance to have that shoulder work like an efficiently working machine. If you ignore some and just work on the muscles you know the names of, like your pec and your delt and your lats, and you ignore those little ones, those little stabilizing muscles are very important to the balance of the shoulder, and you have a breakdown of mechanics. And then you get all these problems like AC joint degeneration, labral tears, rotator cuff tears, biceps problems, and then shoulder arthritis. And we'll get into more of those later. So we'll talk about what's normal, or at least not worrisome. And so people come to my office frequently with things they probably shouldn't worry about. And I've never mind that, but they probably, they could have solved some of these issues themselves, or at least didn't have to come to the doctor for that. So it's normal to have soreness after a hard workout. Sometimes that could last several days. You get a buildup of lactic acid, especially if you haven't worked out much. And so that will go if you have just soreness for a few days after workout, even if it's some pretty significant soreness, I wouldn't worry about that too much. Atraumatic pain that goes away after a few days is also not too big of a deal. So if you don't have any traumatic injury and you have shoulder pain, and then it goes away, but you made the appointment and you come back and people will come to me and say, hey, it was hurting a few days ago, but now it's normal. I don't really have much to offer that person, because if I can't make them better, then pretty good. So that's not anything that really is too worrisome. Noises are one of those things that people are very concerned about, and they'll come to me and they say, my shoulder clicks or it pops. And I say, okay, does it hurt? And they say, no, but I'm concerned about the noise. I am never concerned about the noise. It doesn't really correlate with anything bad or good. It is what it is. It's, some people have noisy joints. I have a lot of noisy joints. They're not of particular concern to me, and they're not really correlated with any bad injury. If pain continues despite you not changing anything, it's a little bit of a confusing sentence, but if you get pain and you don't do anything about it and it doesn't go away, I might say, all right, well, why didn't you take anti-inflammatories? Why didn't you change your workout routine? And if you didn't do any of that stuff, those would be the first steps that I would do, because sometimes that's all it takes. So usually I would say do the basic things before you necessarily have to see the doctor. And then aches that don't inhibit activity. Sometimes people ultimately, it's never a bad idea to get checked out if you have this kind of chronic pain. But if it's this mild pain that doesn't really get in the way of activities, I would say maybe we don't need to treat that. And I think that is all relative, right? And I put 3 out of 10 on a scale, but that could be relative. Some people's 3 is another people's 8. And so we have this 10-point scale that's kind of arbitrary, but still is something that I would say, if you have this mild ache that doesn't really get in the way of life, you probably don't want to do something major to correct that. And there are minor things that everyone can do. So what's not normal? Pain that lasts weeks despite treatment. So usually when there's some kind of problem that lasts more than 2 weeks, I usually say it's worth getting it checked out at that point. And especially if you've tried the basics, if you've tried limiting the activity that caused the pain in the first place, if you tried anti-inflammatories, those are reasons to get checked out. Traumatic pain always should be examined, because some people don't quite understand that there are things that are time sensitive. So if you have a traumatic injury and you don't get it checked out, you might miss the boat on treatment. For instance, biceps ruptures are one of the classic things that need to be evaluated quickly, because there's only a few weeks to get that. I'm talking about distal biceps ruptures near the elbow. And so that's one example. The same thing with traumatic rotator cuff tears. It's relatively time sensitive, so that it's not something that I would wait on for several weeks or months. Weakness is also something that I would not ignore. If you are losing strength in that arm, that is something that should be examined, because that could be correlated with something like a rotator cuff tear or other injury. Loss of motion is also a problem. If you can't move your arm, and we'll get into something like frozen shoulder in a bit, that's something that we can make better with a visit to the doctor. And then pain that prevents sleep and daily tasks is also something that we want to correct that, because if it's getting in the way of life, we should be doing something about it. And so I'm going to go over just treatment options, which is just kind of a generic list. There's going to be some little minor variations. This is going to be for every problem that I discussed today. So rest, I put into quotation marks, because rest does not mean put it in a bubble and keep it still. Bracing and sling use are not helpful for anything other than post-operative, or maybe just a few days after a traumatic injury. Because what happens when you stop moving the arm is it gets stiff. And so we don't want to do that. We want to keep it moving. That doesn't mean, go right back to the monkey bars. That means take it easy from whatever the activity that caused this, but keep the motion. Make sure you can get all the way up, all the way side, all the way behind the back. Even if that hurts, even if you have to use your other arm to do it, you want to avoid stiffness from developing. Activity modification is always a good idea, right? People often come to me with something like saying something like they hurts when they do overhead presses. And I kind of think overhead presses are sort of bad for the shoulder in general. Most people don't do it with the correct form. They overdo it. It's a lot of pressure on the shoulder to do overhead presses. So avoiding something like that, if that's what causes pain, can sometimes be all the answer. NSAIDs are a term for medications that are non-steroidal anti-inflammatory medications. So those are medications like ibuprofen and Aleve. people worry that they're masking something. You will never mask a real problem with medications like this. You will decrease the inflammation. And so the purpose of them is to decrease that inflammation. And so that can be very valuable in the treatment algorithm. And you want to do it with some caution, because some of those medications in patients with kidney problems can be problematic for those organs. So everything obviously in moderation. Physical therapy is the crux of almost all treatment algorithms in the shoulder in particular. Physical therapy works in the shoulder. It solves a large majority of our issues. And so I always encourage physical therapy for patients. It's never a problem. I put alternative treatments, and that's a catch-all term for things like chiropractors, acupuncture, reflexology. Choose your holistic treatment of choice. But these can have a role, especially where maybe Western medicine hasn't solved the issue. I've had people that have done acupuncture and had great success with that. And so I'm not going to, even though I don't understand them, doesn't mean that they don't have a value. And so they could serve a role, though I guess you would always want to take it with a grain of salt, because sometimes if you're ignoring a structural problem by taking these alternative treatments, you could be doing yourself a disservice. Injections can include things like corticosteroids or hyaluronic acid, and then surgery is the last resort for a lot of options, but sometimes it's at the front of the list depending on the problem. All right, so we're going to get into some cases here. So this is a 55-year-old volleyball player. He says he has pain with serving the ball and trying to block the opponent's shots. And now it's painful to even do daily tasks. He's not responding to things like ibuprofen. So we're going to talk about rotator cuff pathology, and that's going to be the biggest category here. And that encompasses a broad range of conditions, including rotator cuff tears, but also things like bursitis, impingement, rotator cuff tendonitis. These are all problems that basically mean inflammation around that shoulder joint. They have some subtle differences between these terms, but overall, that's the problem we're talking about. It's the most common cause of shoulder pain. People ask, what is a bursa? Bursa is just this fluid sac that lies not only in the shoulder, but in most joints. And it basically serves as a lubricant between structures that are rubbing near each other, and that could get inflamed. So rotator cuff tears are extremely common. As if you get to 60 years old and you just pull half of your peers off of the street, whether they have pain or not, and you put them in an MRI machine, more than half are going to have a full or partial thickness tear. So people get very excited about having an MRI that shows some kind of rotator cuff tear. And I try to calm down that enthusiasm or lack of enthusiasm for what it is, because it might have always been there, whether the person had pain or not, and it might be in their other side that's not painful. And if you have a tear on one side, it predicts a high rate of full or partial tear on the other side, both because of genetics and perhaps environment and history. So why does it hurt? I'll go into a little bit of the pathophysiology, as we like to say. So tendons are made of little structures called fibrils. And then there's this layer called lubricin, which is a lubricant between these fibrils that basically reduces the friction between them. All right. And so as you get older, you lose that lubricant and you have increased friction between those microscopic fibers. So obviously friction is going to lead to some kind of almost mechanical wear and pain. And then you get decreased water content, which leads to stiffness of that tendon, as we talked about, less compliance, less flexibility of the tendon. And then they're less able to adapt to high tensile loads. So as you basically are lifting the same amount of weight as you get older, these stiffer, less lubricated tendons get inflamed and they hurt. And so we get to this concept called impingement. So impingement means repeated microtrauma of the shoulder, usually between the underside of the shoulder blade and the top of the humeral head. And in between there, you can see all these layers. There's your biceps tendon, for instance, there's your rotator cuff, and then there is this bursal layer. And so it gets pinched as you kind of lift your arm up. And then the rotator cuff will lose vascularity over time. Vascularity means blood supply. And so you lose blood supply, you lose the kind of healing capacity of these micro injuries, and you get that mechanical irritation between those two bones. You get bone spurs, acromioclavicular joint arthritis, and then thickened ligaments. Also, the tendon is thickened. You get less space between that humeral head and the acromion, and that causes all these inflamed conditions. So you get less space between these bones, and then you can get these hooked bones or acromion over here, which sometimes will shave down in surgery to create more space. So what would we want to do in these situations? We want to decrease the inflammation. So you could do that with anti-inflammatory medications. You could do that with cortisone shots. You also want to address the rotator cuff weakness with therapy and a home exercise program. And basically that will create balance to the shoulder so it hurts less. The keys to successful non-operative treatment is a compliant, motivated patient. You need to strengthen that rotator cuff. Remember, you pull that rotator cuff into the socket to help it be a more efficient shoulder joint, less toggle, less wiggle room. And you want to avoid those symptom-inducing activities. If it hurts every time you're swinging from the rings, maybe you should stop swinging from the rings. And other such examples are probably applicable there. So who needs an MRI? So if you have a traumatic incident, especially if afterwards you can't lift your arm or you have weakness, you need to get an MRI as soon as you can, because a traumatic tear is very different than a chronic tear. Traumatic tears need to be fixed usually within about 3 months in an ideal situation, maybe even less, whereas chronic tears are different. So I always tell people, it's kind of like you have MRI is kind of like a picture of a car on the street, and you tell me, where's that car going to be in 5 seconds? Depends how fast that car is moving. A traumatic tear is moving very fast. A chronic tear is moving very slow. If they failed non-operative treatment, so you tried injections or therapy, then MRI is also warranted. But you have to be a little careful with injections. Injections can make a tear worse. Not that anything will be catastrophic, but it can make it degenerate more, and it can make the tear less likely to heal if you do surgery. There's this group called the Moon Group, which did studies on non-traumatic full thickness tears. So these people have a full tear of their rotator cuff, and they've studied them since 2004. And at 10 years, more than 70% of these patients do well with non-surgical treatment. So people ask, I have a tear, don't I need surgery? And the answer is no, you do not need surgery. A lot of people can do well without surgery. But the biggest risk factor for failure is patients who believe that physical therapy don't work. So again, it's kind of a mind over matter thing. You have to have a motivation and compliance and kind of the right attitude. What happens to cuff tears over time? They will enlarge. It's like a hole in your sock. They do not get better unless they do not heal unless you fix them. So they only stay the same or get worse over time. As you get to the age of 60, you get higher tear progression. Remember I said there's less blood supply as you get older. So with less blood supply, it has more tendency to degenerate and get bigger over time. If you smoke, you're going to make that tear worse, and pain is associated with bigger size and fatty degeneration. So if your previously asymptomatic rotator cuff tear starts feeling worse, you probably should get another MRI because it could be getting worse. And this is what happens over time is this is someone that had a rotator cuff tear and one of their metal anchors fell out, and you could say that's usually a telltale sign that it failed. And then this is what muscle looks like. This is what fat looks like. And so as these are all the rotator cuff muscles that the green arrows are pointing to, a lot of those muscles look like fat. And so over time, as the muscle turns to fat, this is an irreversible change and you can't fix that anymore. So if you're paying attention, I'm giving you two conflicting stories. On the one hand, I'm saying tears do not need to be fixed. On the other hand, I'm saying tears get bigger over time. So which one is true? And the fact is they're both true. And you have to take both into account in decision making. You have to treat every individual a little bit differently. For non-traumatic tears, you could start with non-operative treatment and monitor. And then if you get worsening symptoms or weakness, these are trouble signs. So what happens after rotator cuff repair? You're usually in a sling for a month. It's a very slow healing process. It can be pretty painful and a relatively high failure rate. So that could be up to 50% in big tears. But as a general rule, 10 to 25% failure rate is what I quote for the standard rotator cuff. So it's not insignificant for these not to heal. And again, it's a relatively poor blood supply to this area. And so it's a lot of work to get these to heal. There's no physical work or activities for 6+ months. So that's a lot for someone who wants to stay active and someone who has a physical job. And sometimes takes about over a year to feel back to normal. So surgery is not insignificant in terms of this. So the way I see it, Non-operative treatment for people that have no intact rotator cuff or partial thickness tear. Consider repair in acute full tears. Those I would fix almost always. Then small to medium-sized tears, young patients, and any recent loss of function, I might consider a repair. And then in group 3, for people who have such big tears that they're not worth fixing, I could either do non-operative treatment or do a reverse shoulder replacement. We'll talk again more about that later. This is what a rotator cuff repair will look like. This above is the torn tendon. This is the bone below. And then we put these anchors in the bone, tie them through the tissue, and then sew them down, and that closes the hole. So here's the second case, 45-year-old CrossFit athlete, notes pain with overhead lifting. He doesn't remember any injury, but he gets occasional clicking, and he's worried about the clicking, and then he tries to exercise through the pain, and another physician ordered an MRI, found a slap tear. He comes to me ready for surgery. So this is a labral problem. So labrum is like a giant gasket that goes around the socket or glenoid. That's helpful for shoulder stability in the younger patient. And then the top part of that labrum is attached to the biceps, and that's when people get slap tears. And that's a very common area for people to get tears, and it could be a big source of pain because that biceps is pulling on that torn labrum. But labral tears are very common in asymptomatic individuals. Up to 72% of middle-aged individuals have a slap tear. So more likely than not that you have a slap tear after a certain age. And it's often found incidentally on MRI and may not even be the source of people's pain. So unless there's instability of the shoulder, meaning the shoulder is popping out, which is very rare after the age of 40, it's almost always non-operative. We do physical therapy, we do cortisone injections, modify their activities, but surgical repair can actually worsen the stiffness and pain. So we don't want to do something that makes people worse. And it's usually the last resort and often involves detaching that biceps. Here's a segue to that. This is a 52-year-old man tried to catch a ball, felt a pop in his arm, and then he had bruising and deformity a couple days later. And prior to that, he had been having shoulder pain for weeks. So this is a long head of the biceps rupture. And so the biceps has two heads at the top, one attached to the coracoid, one attached here to the top of the glenoid. And so this one has a tortuous path, and this one can be a source of pain. It's often associated with rotator cuff problems, and it can be a pain generator, but it's not critical for function. So if you get this Popeye sign from this, it could be treated basically a pain. This is a torn biceps, and these can actually be left alone. John Elway and Brett Favre both had complete ruptures of their biceps, and they ended up having much better careers after they got their biceps cut than before. But they might have a deformity there. And so, yeah, John Elway might have won a Super Bowl, but he has a little bit of a deformed biceps. No big deal. Some people get cramping, and those people are a little bit more unhappy with this. But surgical treatment involves reattaching the biceps in a different place. So you trade the deformity for a scar, but a painful biceps can be treated like other conditions. You might want to avoid injections on the biceps tendon because it could cause it to rupture. Here's another case, 54-year-old female pickleball player. She hurt her arm sleeping, saw her primary care, recommended a sling, and then 3 months later, she has pain and inability to move her shoulder. So range of motion less than the other side. And so this is a frozen shoulder. Frozen shoulder means that you lose both active and passive range of motion, meaning even I couldn't move it if she was asleep. And there's not another diagnosis to explain that stiffness like arthritis. So it's poorly understood why this happens, but usually this tissue should look nice and white. In this case, it's really red and angry and inflamed looking. And basically, there's an inflammatory component and a fibrotic component, meaning a lot of scar tissue that's formed. That capsule gets contracted, and then it gets tight, and little by little it hurts more. People stop moving it, it gets contracted, and that cycle continues. And usually there's a inflammatory component, and then it goes to freezing stage, then a frozen stage that doesn't hurt as much, but they can't move their arm, and then a thawing stage. Treatment is almost always conservative with anti-inflammatory medications, physical therapy, injections. If you fail 4 to 6 months of dedicated non-operative treatment, you could consider doing a surgical release and manipulation, but you don't have to. If you leave frozen shoulder alone for 1 to 2 years, it'll probably get better, but most people don't want to give any problem like this 1 to 2 years, especially if it's really painful. So what we try to do is shorten that process and make people feel better. Usually, if it takes more than 4 months of dedicated treatment, according to this study, those people end up usually needing surgery, especially if they had more limited initial range of motion, if they waited longer before getting evaluated, and if they lose motion as time goes on. So the key message for frozen shoulder is you don't want to lose motion after a painful episode. Therapy and injections can decrease the pain and reduce that time till improvement. And if you start losing motion, you need to see your physician as soon as possible. Here's a final case, 46-year-old recreational athlete. He had a shoulder of dislocation, a history of shoulder dislocation when he was in his teens. He's still powerlifting and bow hunting, but he's losing motion and having increased pain. So you can see this guy has lost all his joint space. And so he has osteoarthritis. That's a destruction of the cartilage between the ball and the socket. Almost 1 in 3 people over the age of 60 have some level of arthritis. It's common in patients with a previous shoulder dislocation and has a similar impact to heart failure, diabetes, and even heart attack in terms of how it affects people's lives. So what does it look like? You lose some of that smooth white surface of the joint, and you get this kind of rough looking joint surface. And so you don't have to do anything. It's not cancer. Your arm is not going to fall off. People tell me when they want treatment for this, and you could do activity modification, just avoid things that hurt. You can do anti-inflammatory medications, physical therapy. Injections include cortisone and hyaluronic acid. Hyaluronic acid is a naturally produced substance in the shoulder that helps lubricate. It works fairly well in the knees. It's so-so in the shoulder. Our National Society actually says not to do it because it doesn't really make a difference. But I certainly have patients that say they like it, and so they usually will choose it over a cortisone shot, and I'm not going to argue with them if they say it works. And then there's shoulder replacement. And so I consider various things like age, other medical problems, how much it affects them, how their rotator cuff is functioning, and if they have any deformity when making a decision about a shoulder replacement. The designs have changed over time from long stems to short stems, and there's arguments to be made about whether there's any difference between any of that. There's things called reverse replacement, where you replace the ball with a socket and a socket with a ball. It was developed in France, and the French are actually ahead of Americans on a lot of shoulder things. So they've done a lot, they've created a lot of innovation for the shoulder world. So my algorithm is if a patient can tolerate the pain, they just get non-operative treatment. There's no reason you have to get an option for this. If they're arthritic and young, you could consider just replacing the head. And there's these new implants with pyrocarbon as opposed to metal that is actually maybe revolutionary, but still fairly early. In Europe and Australia, they've had great results. But here we're still figuring out whether this is going to be something. But basically, without the plastic component of a ball inside of the total shoulder arthroplasty, these can have longer lifespans, and so that's very promising. I've been using it in select cases and have had really good results with that. If both sides are arthritic and the rotator cuff is good, you get what's called a total shoulder arthroplasty, where you replace ball with ball and socket with socket. And if the rotator cuff is bad or severe deformity, or they're very low functioning, or they have a fracture, they get a reverse shoulder arthroplasty, which is a great option and actually is much more popular than any of the other options that I've listed. It's the most commonly used. So in this case, this is a total shoulder arthroplasty with a metal head and a plastic socket. So I'll quickly go through this because we're running low on time, but you want to have all these components in order to maintain longevity. So you want to have, if you want to be like Tom Brady and have a long career, you want to have good diet, meaning do the things that we all know we're supposed to be doing: weight training, cardio, flexibility, and balance training. So I'm not a dietitian, but we know we shouldn't be eating hot dog contests. But you want to have high protein, more protein than you think, a high fiber diet, balanced nutrition, and avoid excesses. Weight training is probably it's becoming more and more found to be more and more important to slow that muscle loss that develops over time. And that could be body weight. It doesn't mean you have to be world's strongest man, but body weight and resistance can be helpful to improve bone density, metabolism, and muscle loss. Cardiovascular fitness can lead to resilience to injury, and usually 20 to 30 minutes a day, 3 to 5 days a week. flexibility is important to get rid of that loss of elasticity to avoid those micro injuries. And so eccentric exercises where you strengthen while you lengthen, think of lowering a heavy weight rather than lifting the heavy weight, can help resist injury and allow more range of motion before you get injury. And so things like plyometrics, stretching, and yoga can improve the resistance to soft tissue injury. And then balance, again, because falls can be life altering. One bad fall can change the course of your life. So, and balance decreases over time for a complex set of reasons, from muscle loss to inner ear changes to brain and nervous system changes. So incorporating a balance program into your fitness can avoid catastrophic incidents. Agility training can help with change in direction. And again, yoga, single leg balance, and uneven surface training can all be helpful. And then biologics, people will always ask about this. My basic thoughts on this are they have limited evidence with a lot of industry bias. You cannot solve a structural problem with chemical solutions. And we could answer more questions about this, but they may have a role in limited settings. I use PRP myself for certain things. We talked about hyaluronic acid, but you want to be careful because a lot of this, again, is biased in terms of its use. But there certainly is a role, especially for things like partial thickness tears and tendinopathies. So in summary, the shoulder is not immune to the effect of aging. Prevention and maintenance can avoid those longer term problems that develop, and many treatment options exist, but you have to know when to call for help, and obviously prevention is the best medicine here. So thank you for the time, and thank you for this opportunity. I'll open it up to questions.
All right, thank you so much. Are you ready?
Ready.
Okay. Joel asks, are there basic exercises that should be done to strengthen the muscles around the shoulder and the rotator cuff?
The answer is yes. I mean, there is a whole series of exercises that obviously, the therapists know a lot about, but, what you want to do is balance the whole shoulder girdle. And, I'm not trying to have everyone understand the anatomy of the shoulder, but the ones that you usually will use in therapy are resistance band exercises, doing internal and external rotation. So internal rotation means going in like this. External rotation means going in like that. And you could do it in this position and you could do it in this position. And usually I tell people that this is like eating your vegetables before having your main course. If you have a shoulder problem, you want to incorporate those rotational exercises into your routine so that basically those muscles are engaged before you start doing things like the bench press and the pec flies and whatever else that you like to do to lift weight shoulder. You also don't want to ignore your shoulder blade muscles, the ones that keep your shoulder blades retracted and back. All of us tend to kind of hunch forward over time, especially as we're sedentary and we're working on our computers. There's not as much of a daily use of bringing your shoulder blades back in that optimal position. So I would say I would encourage people to focus on those. There's plenty of online resources for that. There's the AAOS, which is our American Academy of Orthopedic Surgeons, home exercise program for every part of the body, one of them the shoulder. And that's a reasonable one that I will send to patients, or if patients want a home exercise program, to basically reference that. So hopefully that answers that question. That's a big topic. Obviously, you might need to talk to a personal trainer or therapist to get more details.
Oh, but that's great. And that you're letting people know, just move those shoulders throughout that range of motion and strengthening all around. I thought it was perfect. So thank you. Okay, next. Do you partner with physical therapists to determine the exercises that someone does?
It's a good question. I think I don't micromanage that relationship that much. So therapists have a whole set of exercises and whatnot that they have for every particular problem. And, every therapist is going to have sort of a different comfort zone of what they like to use. And I give them that freedom for that. Obviously, if there's a particular problem that needs particular types of exercises, then I will stress that in my in my instruction. So for instance, like if for a frozen shoulder, my focus is on range of motion, not necessarily strengthening. Those people don't need strengthening. They need to be stretched out. You have to take that with a grain. You don't want to stretch them out so hard that they're set back for several days, to have sort of this give and take with the patient. Same thing with post-operative protocols. Sometimes I want people to be limited in certain things because I want to protect whatever I repaired. So there's an element of me directing the therapy. Often I kind of give some freedom to the therapist within some parameters so that they can kind of get creative with what they do because they're professionals of themselves.
Great, thank you. Great answer. All right. For someone who has what they would consider bone on bone in their shoulder joint, do you want them to still have strong rotator cuff muscles and have tight rotator cuff muscles?
I do. I think it's always important to do that. And actually, physical therapy, it's a little bit controversial in terms of shoulder osteoarthritis when you're bone on bone, because it's unclear if it provides benefit and if it helps people avoid surgery. But in either case, I think strengthening those muscles is really important because even though you have an arthritic joint, you still want a balanced joint, and a balanced joint will always do better than an unbalanced joint. So yes, I would say you want to strengthen those muscles. It also makes the difference for people that want to do a standard shoulder replacement. You need good rotator cuff muscles, otherwise you're getting the reverse, which is not a bad thing, but some people prefer the standard anatomic replacement because it kind of acts more like a normal shoulder. The reverse replacement changes your anatomy completely. So if you go years and years with neglecting your rotator cuff because it just hurts too much and you have a shoulder osteoarthritis, and then you come to me and your muscles have all atrophied, well, you're getting the reverse, which again is not a terrible thing. People do great with reverse and they can do anything they want, but still, I think leaving all your options open and having strong shoulder girdle is important.
Great, thank you. Okay. Let's see. So these are the ones that came in after. So I'm trying to, let's see. Can you describe the recovery for a reverse shoulder replacement compared to a standard shoulder replacement? Is the recovery different?
I think I can only speak to my protocol, and there's going to be some variety on protocols. So here's the difference. For me, the thing with the reverse replacement is once it's in, it's pretty much in, and you don't worry about too much except for shoulder dislocation. Okay, so the reverse can dislocate, it can sort of jump out, and then once it's out, it's out. It doesn't have play like the standard replacement does. So basically for me, the reverse replacement, you sort of rest for the first month, and then you kind of move quickly because you're not protecting any particular structure. Standard replacement, you have to cut one of the rotator cuff muscles called the subscapularis and then reattach it, and that has to heal for it to function properly. And so during the recovery process, you have to protect that repair. And so for me, you actually start a little sooner with the anatomic shoulder replacement. So you start at 2 weeks, but you start and you go slowly, as opposed to reverse, you start a little later, but you move a little bit quicker. And then they end up usually about the same. I think it's by about 3 months, I let people do whatever they want. And again, these are my particular protocols based on my experience and whatnot. And it's different. I have surgeons that let their reverses do. I know surgeons who let their reverses do whatever they want, pretty much from day zero, which I may be cavalier. They're right. I don't know, but I worry a little bit about the dislocation risk, which is only there for that first 4 to 6 weeks usually. And with the anatomics, usually again they end up they might feel a little bit better because their shoulder is kind of naturally aligned as opposed to re-engineered. Either way, I think the difference in the recovery is fairly similar. I wouldn't really make a big distinction between the two because 3 months is over in a blink of an eye when it comes down to it. And so if you're about the same point at 3 months, then I don't think it really makes a difference.
Great, thank you. Is swimming a good exercise for shoulder health?
Swimming is fantastic. I think that's probably one of the best slash underrated exercises for the shoulder because it provides resistance without, impact, so to speak. And so you're in this weightless environment. It's really good for shoulder stiffness too, because it kind of forces you through that arc of motion repeatedly and again, a weightless environment. So yeah, I encourage it all the time. Obviously, swimming can lead to shoulder problems too, especially if you're doing it with improper technique. So it's a double-edged sword like anything. But yes, and I would kind of, instead of swimming, I would say water exercises of various kinds. But I think swimming is fantastic.
Great, thank you. Okay. How common are injuries to the teres major or the lat in impeding movement or mobility of overhead throwing athletes? And are these injuries considered injuries to the shoulder?
Wow, that's that's a deeper dive kind of question. The short answer is not very common, at least not in a sort of rigorous way. I think you will hear about people with traumatic latissimus tears that need to be repaired. Those are very strong joints, and they're not commonly injured. Now, one might argue that there are some micro injuries that maybe are unrecognized because of working on other diagnoses, and maybe there's an imbalance of the whole shoulder girdle. And pitchers they're a unicorn in the world, right? There's I don't know what percentage of the population is a pitcher, but they have extremely unique type of injuries and problems. So yeah, I mean, short answer is when we're discussing these at our conferences with throwing athlete experts, I wouldn't say that teres major and latissimus is very high on the list of things that we discuss very frequently. And I certainly don't see it. So I would put this into the uncommon category, but maybe unrecognized, so I will leave it at that.
Okay, yeah, no, that works. That sounds great. Can a neck injury lead to a shoulder injury or vice versa?
There's a lot of interplay between neck and shoulder pathology, and it's more of an issue of there's a confusion about which one it is half the time, because people will often mistake a shoulder problem for a neck problem and vice versa. And so, long story short, the neck has all the nerves that control shoulder function and shoulder pain, that matters. So when you have let's say a pinched nerve in the neck, people will come to me and they say, my shoulder hurts. And I examine their shoulder, and their shoulder is completely normal. And then I move their neck and like, wow, that made my shoulder hurt. And I realized that it's just a pinched nerve. Their body's interpreting the neck problem as a shoulder problem. Now, for that, let's kind of flip that script a little bit. Let's say you have a shoulder arthritis, a badly arthritic shoulder, and you can't move your arm in a certain way, and so you are contorting a lot of things in order to do the same activity. So you're reaching up, and instead of reaching up, you're kind of arcing and everything like that, and then you're getting neck problems because of that. So compensatory activities can lead to problems in the neighboring joint, and so that happens with shoulder and neck pathology. So a lot of interplay between the two. So I would say yes, if we were going to answer that with one word.
No, that was good. That was good. All right. How about using a rowing machine for an arthritic shoulder? Is that a good exercise?
Sure. I think a rowing machine is great. I would say that, a rowing machine does a similar thing to swimming in the sense that it forces motion in a certain arc. Now, it doesn't take advantage of the whole arc, but let's say someone cannot do this because they have shoulder arthritis. They can't lift their arms straight in the air, but they want to maintain shoulder strength. And so a rowing machine will provide that by forcing you to kind of pull your scapular muscles back and provide a lot of strength. I mean, I think a rowing machine is a great exercise. Obviously, people get injuries from rowing machines frequently if they're not doing it with correct. So that's what I would always encourage, is just do it with correct technique. I think with shoulder arthritis in general, you want to avoid the like high weight powerlifting type of exercises, because that will actually, by powerlifting, you are grinding that joint more. So if you're, maxing out, lifting 500 pounds with your bench press, you're probably going to make that arthritis worse. So the idea is do low weight, high rep type of activities, and a rowing machine is just that. You kind of have this low resistance, but you're doing it over and over again and creating endurance around the shoulder. So yeah, exercise for shoulder arthritis, but obviously make it hurt too. So if it makes it hurt, then maybe there's your answer.
Got it. Great. All right. It turned over to 8:01, and I try to never keep doctors late on these programs. So for those of you with more questions, please reach out to Dr. Petkovic on your own. His information's right there. Dr. Petkovic, thank you so much for your time this evening. This was fabulous. Great information, great answers to questions. I think we learned a lot tonight. Have a great night. Thanks. Take care. Appreciate your time.